My name is Robert Alter. Today we're going to discuss a case involving a 58-year-old gentleman who presented to his primary care physician complaining of anorexia and fatigue for several months. Patient had a moderate weight loss of 15 pounds. And after the patient was seen by his primary care physician, the appropriate workup was performed with the patient undergoing laboratory assessments, including a CBC, chemistry panel, including calcium and an LDH, a chest x-ray and a CAT scan of the abdomen and pelvis. It was discovered the patient to have a renal mass measuring 10.3 centimeters in size. After ruling out any evidence of metastatic disease, the patient underwent a left total nephrectomy with surgical findings and pathology findings all consistent with a stage 3A disease. Pathology findings including a 10.2 centimeter renal mass included renal vein invasion. Otherwise, all margins were negative, with 2 lymph nodes resected, negative for metastatic disease. The patient then underwent active surveillance. It was discussed with the patient initially the concerns of risk of recurrence, considerations for adjuvant therapy. Active surveillance was recommended. The patient underwent surveillance testing with scans performed at 6-month intervals. And then in March of 2019, the patient who was asymptomatic was noted to have on chest x-ray and subsequent CAT scan of the chest, developed of pulmonary nodules, the largest nodule measuring 3.5 by 3 centimeters in size. Soft tissue disease was noted, as well as mediastinal adenopathy. And analyzing the patient's case, the patient was considered to be an intermediate risk, with patient having recurrences within 1 year, an ECOG performance status of 1, and with the patient having intermediate risk stratification, categorization. The patient was started on clinical therapies consisting of axitinib at 5 milligrams PO once a day, 5 milligrams PO BID, as well as pembrolizumab 200 milligrams IV given every 3 weeks. The patient had excellent tolerance to therapy. Initial scans performed 3 months after initiation of therapy. They noted a 60% reduction in disease, considered to be a partial response. The patient had nominal toxicities requiring no dose adjustments with the axitinib therapy, and subsequent scans performed in September 2019 revealed disease progression, with pulmonary lesions increasing to 5.0 by 4.5 centimeters in size, increase in size and development of new mediastinal adenopathy, and hilar adenopathy, with the patient still having an excellent function performance status. At that time, the patient's therapy was changed to avatinib at 18 milligrams PO daily, along with everolimus 5 milligrams PO daily, for which the patient began in October of 2019. At first assessment, 4 weeks after evaluation, the patient was noted to have grade 1 diarrhea. Dose of avatinib was decreased to 14 milligrams daily, while the dose of everolimus remained the same. The patient had scans performed in December of 2019, which revealed pulmonary lesions decreasing to 2 centimeters in size, indicating a partial response, with the patient remaining on therapy last seen in January 2020, continuing on avatinib at 14 milligrams PO daily, along with everolimus 5 milligrams daily.